Good morning, Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dolph Simons Family Studio, and happy to be here on this beautiful Monday morning. I'm joined, of course, by Hawkeye on my right, and on my left, Dr. Jamie Wagner, the head of breast cancer surgery here at the University of Kansas Health System. Elizabeth Monks, one of our cancer center psychologists, is also on the line with us. She'll be joining us momentarily. But first, Hawk. Okay, this is not a good weekend, man. We are setting record numbers, and our rise is faster than I would like.
Yeah, absolutely. This is what we had feared. You know, we're significantly concerned about for capacity issues, vital drug issues, workforce issues. You know, since last week, our numbers had continued to go up. And if you go to kansascity.com, you can actually see from the late October, 10 or more days ago, when the cases started to rise, we know hospitalizations lag behind cases. So unfortunately, since last week, our cases have continued to go up. We have 68 acute infections in the hospital. Before we had, 50 to 60 acute plus recovery. Right now, it's 68 acute infections. People are coming in for COVID-19. 26 of those are in the ICU too, so that's a large amount of people. And then 14 are on the ventilator. We still have 28 who are in that recovery phase with only 3 on the ventilator, so that's a good thing. And luckily, Hays has stayed kind of stable. They were at one point at 20 or 21, but right now they're at 17 with 12 active and 5 in that recovery phase. So if we can keep those rural areas, especially with less resources, with as few as cases as possible, that's a good thing.
Yeah, that is a good thing, but those are really high numbers. So our combined total now is at 96. That's as high as we've been. And how long ago was it we were at 35? That feels like it's kind of in the distant mirror now.
Yeah, and I don't think it was that far.
I didn't feel like that. And the other disturbing trend is what's going on in Kansas City. 2 weeks ago, the average number of positive new cases a day was 350. Then it was 700, and now it's pushing 1,000 or over 1,000 the last 3 days. That just portends not so good for what's going to happen to the healthcare in Kansas City. We also know that everybody around the city is having an increased number of COVID-positive patients. We had our CMO meeting last week and with reporters and elected officials, and just to say, man, the message out there is that we're getting tight on beds in Kansas City. So
and it's all ages.
It is all
young
ages.
people. It is older people. I have a family friend, 6 of 6 in their household have COVID-19. So these things are out there. And what is more concerning is it's still nice out. Wait until Thanksgiving and Christmas when it's not nice out and people aren't going to be really doing anything outdoors. And getting together all indoors.
So that 6 out of 6 was from a Halloween party. Is that what you said?
It probably originally started there.
Yeah, that's tough. Jill, let's first see if there are reporter questions.
This is Brian Grimmo with the Kansas News Service. I was just wondering if you look at some of the numbers in western Kansas and some of these smaller counties like Norton County, and if that has you concerned for Hays to see that the per capita and the percent positive is really high in some of these western Kansas counties, and if that has any concern for your center out there in Hays.
Yeah, it has a lot of concern. It has a lot of concern in Hays. We are alarmed by the high per capita ratio. You're right that when we look at cases per 100,000, some of the counties in Kansas City are some of the hottest spots in the country, and that is worrisome because eventually those patients, especially as it gets into an older population or if it gets in the nursing homes where there are a lot of nursing home outbreaks in Kansas City now. But those patients then translate into folks that have to move to higher levels of care because most patients, if they get really sick, can't stay in a really small hospital. They're going to need critical care. They got to go to Hays or someplace like that or Salina, and then those hospitals get overwhelmed. And I know that Wichita is further along that curve than Kansas City in general. In discussions with Lee Norman, this weekend, and so I think that but we're all we're just nervous about what the future holds, and the thing is we know how to bend the curve, and I think that between COVID weariness and not wanting to, we're just tired of it, and so people are not taking the same precautions they took back in March and April, which allowed us to bend the curve. We can bend the darn curve and keep folks safer and not overwhelm hospital capacities. We come at this with a very clear perspective, and our perspective is how do you make sure you take care of patients who are sick? When you look at the data coming out of New York or Italy or other countries where they were overwhelmed, the problems about why people died are linked as much to staffing and getting the right care as they were into ineffective therapy. Because we've got we got better therapy right now with knowing we should put everybody on anticoagulation, knowing we should give everybody steroids. We can use remdesivir. Convalescent plasma may or may not be very effective. It's actually looking more not now. So then it becomes a question of, wow, if we do these other three things, what's the reason we're going to lose folks? And the reason is A, the disease is bad, but B, we're not able to offer all the care we need. And that's what we're worried about when healthcare resources get overwhelmed. So the answer has got to be, help us bend the curve, because you may have heard this morning some remarkable news that Pfizer released with a 90% reduction in COVID transmission. Well, we don't really know what it exactly is, but they said 90% effectiveness of their vaccine. Now, again, that's really early data, but it's the first signal we've seen in humans that says vaccination can work. If that story holds, if it really is a 90% reduction, okay, that is a true game changer. Yeah. That's like Patrick Mahomes in the fourth quarter with no defense on the other side. I mean, we're going to win that game. But we have to get there, and the way we get there is to bend the darn curve. The way to bend the darn curve is to follow the rules of infection control. Yes, we are very concerned. We're concerned that if those numbers per capita in rural counties hold, healthcare in Kansas, and especially in rural areas, even with places like Hays, it's going to struggle to keep up with that load. Other questions?
Hi, guys. It's Taylor Himness from Channel 41. How are you this morning?
Hi, Taylor.
We had a story this morning from Clinical Reference Labs in Lenexa announcing they're going to be selling these tests. And I'm sorry if you guys already talked about this. My call dropped out for a second. But they're going to be selling these home-based tests, the saliva-based tests, starting today. Can you just update us again on the efficacy of saliva versus the other tests that are available, and what you see as the pros and cons of a test like that where you can take it at home versus going someplace to have a test taken?
Hawk, home-based saliva test.
Yeah.
It's not that new. I mean, university people have mailed those to people, let them come back.
Yeah.
And saliva testing works pretty well.
Yeah, I think so far what we have is the data is very good. It's quite considerably the same sensitivity as the NP, the nasopharyngeal, which is the gold standard. And we have used those, just as you stated, with that mass migration with the University of Kansas and Lawrence. But the important thing to do is also understand that when you do that test and you have to mail it back, if you are symptomatic or if you are an exposure or a contact, you probably need to continue to quarantine and isolate until you get those results back. And just understand that that test is for that point in time, and there's nothing to say that 24, 36, 48 hours later you can develop symptoms or have a change in your clinical presentation. So just understand that. But so far it looks like the saliva test is going to be good for that. It's just going to be getting the turnaround time and remembering to stay home until you get that result back.
But we're pretty confident saliva testing does do a good job. Probably better than antigen testing, really.
Yeah, absolutely. I would say definitely better than antigen testing. We know for the most part, most people do get infection first in their upper respiratory tract, so we know that the viral titers can be high. And that is what we are detecting is if you give the sample correctly, you will have a lot of viral titers. It will be a lot easier to pick it up on that PCR test.
Next question, or other questions?
I have a couple from Channel 9. One of them is, you talked about the Pfizer news this morning, and the question is 90% effective?
Yeah, so we don't really know what 90% effective is. So let's be clear. What Pfizer has said is that out of their 30,000 people, they had to have, I think, 130 cases, 140 cases of COVID in those to determine how well the vaccination worked. And they were going to do an interim analysis at 32, and then they stopped and said, "Oh, listen, we're accumulating cases so fast because there's so much coronavirus spread right now. Let's do it at 64." They ended up being able to do it at 96 or something. Those are general numbers, but those are directionally correct. And they claim 90% effective. Now, we don't know what 90% means. We don't know if that meant a 90% deep drop in transmission, that 90% of the cases occurred in the placebo arm and not in the treatment arm. We don't really know. So they didn't tell you what it meant yet. It's an interim analysis. They just got it released to them yesterday about 1 p.m. Eastern time. And so they then came out with it early this morning and said, okay, this is what we're seeing. We're thrilled with these results. This is great news. But the rest of us haven't seen that information and that data yet, nor I don't think will we, because it's an interim analysis that the company has on.
Yeah, absolutely. And the only thing we can really glean from the news outlet is really that, just as you said, they had a number of cases, and only 10% of those cases were people who were vaccinated. So I think they're drawing that 90% from that. And I will stand corrected once the analysis is out and the data is presented, but I think it's a decrease in the disease, not the infection. So infection means if you're exposed to it, can you still replicate the virus but not create any disease or symptoms? I suspect it's more of the disease than the actual sterilizing immunity, protecting you from full infection. So,
because that's how vaccination works, really, right? It makes you have a lower level of disease, or it can help you prevent getting disease.
Yeah.
But like with influenza, you can still get the disease with the vaccine. You're supposed not to get
right.
sick.
Like I believe the measles vaccine is pretty sterilizing. It protects you from infection. I think this doesn't necessarily protect you from infection, but protects you from disease. But again, I'll stand corrected whenever we see what their outcomes and their data was.
So listen, that's really good news, and I think we have to treat it like really good news, because in the middle of COVID weariness syndrome, we all need some good news. I think that's good news. I think the monoclonal antibody stuff is good news. There's another study, now granted it's looking at ferrets, of using a nasal spray to help protect against the coronavirus. It's a very fascinating idea. They basically put a zipper around the spike protein on coronaviruses. It's kind of cool stuff. But it worked really well in ferrets. I don't know if it's going to work in human, but a nasal spray, man, I'll take that.
Sounds like all the minks in Denmark need that.
They do all need that, and wherever the minks may be.
Wherever they are.
Yeah.
No kidding.
Okay. Other question from
Yes. All right. So in post-election conversation, there's talk about fast-tracking COVID-19 tests for at home. Is this possible? What do you see as a timeline, and how could that change the course of the pandemic?
Yeah, I don't think, just to be honest, I don't think that's a post-election conversation. Fast-tracking COVID-19 tests at home has been part of the picture overall. People have been working on that for quite a while, and I think that's exactly what this salival testing is. And the question is, are we getting closer, Hawk, to being able to get a result at home, kind of like you would do a pregnancy test?
Yeah. And that is going to be important. You know, that is one theory that is backed by a lot of scientists and physicians. More access, more readily accessible testing, especially for home, and rapid results that are accurate. So that is not new. It's been going on. It's just, how are we going to be able to get that? And is it the antigen test? Is it a home-based, other molecular type test like a PCR type test that you really don't need all the instruments or all the operator training or anything like that?
So we'll see, but more to come, I think, around that. But it would be a game changer just to say, if you could check yourself every day at home and you know you're positive, so you can't go out and you're negative, okay, I can go out, I can go to the Chiefs game or whatever, then I think, man, that's a lot better. I mean, that would put us in a much better position. That plus vaccination plus monoclonal antibody therapy and whatever the ferret sauce is. The ferrets need a spray. So, okay.
All right, last question that I have for media currently is, when you look at where we are now and you go back to when we were under lockdown earlier, what is the hospital situation?
So when we were under lockdown, we did that because we were afraid of an overwhelming surge, because that's what had happened in New York City, and we didn't have the PPE, and we didn't have the bed capacity to handle that, and we didn't have the training yet around our new processes. So that was a different point in time. Now, we never got the overwhelming surge that New York had, right? And in part because we did a great job of locking down and shutting down society, and it because we had the right for a while. Our curve was looking pretty concerning, but man, we flattened that curve, and that was great. I will tell you, we are in more trouble now than we were then, and the reason we're in more trouble now is there is widespread community transmission of COVID-19, and we know that that can result in people who get sick, and we know that that can result in people who need to be in the hospital, and hospitals now are getting close to capacity. So we're in more trouble now than we were in March or April, but frankly, that's with the retrospectoscope, and it's always easy to look backwards and say that, right? Because we did some things then. Had we not done a shelter-in-place order, I think we would have been in a little bit of a worse situation. Had New York done a shelter-in-place order before the disease got there, they never would have been so overwhelmed. So it's easy to look backwards and say those things. What we can say right now is that we're in a little trouble. And the only thing that's going to work, because we don't have effective vaccination yet, we don't have therapy that you can use at home yet, and we don't have testing that you can use at home yet. Those things are all coming. They are probably, anywhere from 2 to 6 months away. Those are game-changing events. So we won't be here on the morning media program every morning talking to you about COVID. We'll all be really happy about that.
Right.
But in the meantime, we're going to keep preaching the same gospel we've been preaching all along, folks. You've got to bend the curve, because we're in more trouble than we've been in. And if you don't take action now, it's going to get worse, and it's going to overwhelm the hospitals and things, and that is not where we need to be. And you have the power to change the curve. We don't have the power. We do not have the power. You have the power, and we need you to help us if we're going to keep Kansas City safe.
Let's do one last call for reporters. If you'll take that clip.
Yeah, I know it's bouncing everywhere.
It's got
there,
it. You have it.
off. There you go.
There you go.
Thank
Right.
you.
Last call for reporters. All right.
Okay.
Move on.
Jamie Wagner, how are things down at the cancer program?
Good.
Tell us a little bit about yourself and talk to us about what's going on down there.
I'm Jamie Wagner. I'm a breast surgical oncologist. I've been with KU a little over 7.5 years now.
It's been great, by the way. Thank you.
Thank you. We've done some really wonderful things since I've been here, so it's exciting. I have a phenomenal group of people in the program, so
You do.
it's teamwork makes the dream work, and we are evidence of that.
Yeah, you are.
Yeah, so we are just coming off October, Breast Cancer Awareness Month, so we are seeing more, but overall, we're not seeing enough diagnoses, and that's the big concern right now, because what we're seeing, it's more advanced stage breast cancer.
Yeah, we're going to return to that point. I want to come back to this point in just a second, but I also want to introduce Dr. Elizabeth Monks, who's a psychologist in the cancer program, who's going to talk to us about how we cure COVID weariness syndrome. Dr. Monks, you've been on the program before, so thanks for coming back again.
Absolutely. Thanks for having me. The cure to COVID wariness, I think we're still working on it. Managing anxiety is tough, and there's a lot of apprehension, but sometimes I think we get really focused on getting rid of worry or getting rid of apprehension, and we need some of that to make sure that we're keeping ourselves safe. Like, some degree of anxiety is a good thing, right? It signals us that we need to take action and do something different. So while at the Cancer Center, where our psychology team is trying to help patients not only manage the distress of dealing with the cancer diagnosis and treatment, but also the COVID stressor on top of it.
Yeah, it's really hard right now, and I'm sure you spend time talking to the cancer patients about, gosh, you still got to get your treatment even though COVID's out there.
Absolutely. I spend a lot of my time working in the heme division in the BMT program. I also have a host of breast cancer patients and other cancer patients. Treatment must go on. And I think sometimes hesitancy around screenings, like, I don't want to have to come out or go out if I don't have to. But I think if you, especially for breast cancer screenings, like, don't skip your mammograms. If you find something concerning, take control, because the apprehension is only going to grow if you don't do anything. And I think at the Cancer Center, we're taking all the precautions we possibly can to make sure we're keeping our staff and our patients safe so they can come in and get the treatment and screenings that they need.
And Dr. Wagner, that's a problem, because we're seeing data, as I recall, that says, gosh, because people aren't getting treatment, you're seeing more advanced breast cancer than you otherwise would have.
That's right. So there's a couple of unfortunate and shocking pieces of data that has come out over these last several months. Overall in the country, we are down by just over 50% for breast cancer diagnosis. And what that then leads to is women are finding it at more advanced stages, and that's when they're finally coming in, is after they can feel it, versus what that screening mammogram would have otherwise picked up at an early stage. That dramatically changes the breast cancer treatment that we then are able to offer patients, and a lot of times it's much, much more significant types of treatments they're having to receive.
So let's say it again. Breast cancer diagnosis is down by 50%. We know COVID is not curative of breast cancer, nor does it prevent breast cancer. So that's just people being afraid to come get their mammogram.
That's right.
Oh man, we can't do that.
No, we can't. And in October, we saw the number of diagnoses rise, but that's what we see every year. And it isn't in proportion of the numbers we were down prior to October.
Yeah, that's scary. And we know that hospitals are safe because we've re-engineered. And back to that original question from Channel 9 about, is it worse now or worse then? One of the things that is much better now, even though community transmission is widespread, and please don't do that, and please bend the curve, even though that's true, hospitals are safer than ever because we've totally re-engineered how we run clinics and how we do inpatient work.
Yeah, absolutely. All those protocols in place that were really fluid and dynamic early in the pandemic, we've really settled on very good procedures. We have very good PPE stores now. There are masks available. There's eye protection. And it's all geared towards keeping the patients safe from each other, keeping the patients safe from the healthcare workers, and keeping the healthcare workers safe from each other as well. And so we have been able to do that. And right now, like you had said, the PPE stores are good at this point in time. There was shortages before. Right now we're doing good, but as we continue to see more numbers, we don't know how that will affect it as well. So, but overall, the protocols and standards that we have right now are a much better place than we had in February.
And Jamie, tell us some of the things that are going on in your clinic, or just getting a mammogram that helps keep people safe.
Well, I think that there's a lot that actually we have done. First and foremost is just how we're bringing patients in for mammograms. So we are spacing the mammograms out as far as the time slots. That's actually, I think, an opportunity for patients because we have online scheduling, and that has definitely been beefed up through this process. So you can know exactly what time to come in, and your exposure to other people can be very low because you're not waiting in a waiting room very long for a mammogram, like if you're just going to walk in. And another opportunity with that is you can choose to be at the beginning of the day. There's always less backup in waiting rooms at the beginning of the day, so you can know exactly when you want to come in. The throughput is going to be very quick. We have spaced out patients and how they sit in waiting rooms. The sterilization process of all equipment has really been expanded, so there isn't any concern as far as the sterility of the mammography and ultrasound machines that we're using. And then clearly we're all using all appropriate PPE from all the technicians and physicians. We've actually done a lot in our clinics as well. We have a multidisciplinary clinic, which I think is another benefit for those women that do have a new diagnosis of breast cancer, where every member of your treatment team is there and you're not having to move. You are isolated in one room. Everything that you possibly need as far as education and the first stages of treatment planning happen that very day. And now we're reducing the number of times that people are just having to get out in the community.
And I think that we've said before, Elizabeth, that people can be safe here. What can they do to work on that anxiety level that they have about coming in? What kind of advice can you help us give for patients, especially those who don't want to come get a mammogram? Because, I mean, gosh, 50% reduction in diagnosis, bad idea.
Right. I think I try to, with the screenings and avoiding coming into the cancer center, I try to appeal to let's get ahead of the worry or ahead of the apprehension or ahead of the anxiety so that, you know, this is something that you have control over. You can come in, you can get your screening, and that we can all work through worry. You know, even though we might have some anxiety, there's an interesting curve that there's kind of an ideal amount of anxiety or an ideal amount of stress that actually motivates us. And so sometimes when it gets to be too much, it can inhibit us. And when it's not high enough, we're not as motivated. But trying to remember that just because we have a little bit of apprehension or we may be scared, call a support person, talk to somebody else who's gone in and gotten a mammogram, talk to your doctor. Our oncopsychology team is doing lots of telehealth appointments. So you could always chat with one of us and we can give you some more tips and tools, relaxation techniques, breathing techniques, ways to change up your thinking to help you get through these situations. And those telehealth visits can happen from home, so you don't have to come in to see us, and we can help manage some of that stuff.
Yeah, great advice. Well, Jill, let's turn to our public and see what questions are out there. I bet there are a lot.
There are. Okay, I'm going to start with Sarah. She said that she was in a COVID vaccine trial, and she started having a lot of breast pain, mainly in one breast, and then it moved to another. They told her to go and get an MRI. There was nothing that came out clear evidence of breast cancer, but they did find some dense spots. And her question is, they said, come back in a year. She's wanting to know, I think, do you agree with that? And should she get maybe a second opinion?
So, Len, let's be careful. We try not to offer specific medical advice because you'll never know the whole story, but as best you can.
Yeah. So, I think that there could be a lot more that needs to be worked up. I think the overall thing is the old school thought of breast pain isn't cancer. That's not true. And so if she still has a concern, I just really encourage women to be their own advocate and not just take a reading. And it needs to be correlated with a good conversation with their physician and get a better understanding of what's really going on, what that image result meant, and what would be the right next steps. But if she still has a concern, she should follow through on her concerns.
All right, next question.
Yeah, Donna says, I haven't felt real whippy over the weekend, so I went online to see where I could get tested. Johnson County looked like they were completely booked for the week. CVS around me also looked full for the next several days. Frustrating. Why is testing so limited? Should I even bother if I can't get tested in several days?
What you think, Hawk?
I think you should bother. I think doing what you did is good, but I also would also recommend trying the health systems, whether it's University of Kansas Health System, Advent, Truman, St. Luke's, all of those other places as well.
And talk to your primary care physician, because they probably have a way to get you tested as opposed to trying to do it all on your own. If you don't have a primary care physician, then you can go to call one of the urgent care offices or something such as that. But try to call your primary care physician, because I know we actually still have some testing capacity.
Yeah.
I know several hospitals do too. You just have to make sure you call one of their COVID hotlines and try and get a test scheduled.
Or LabCorp or Quest, maybe they have testing available. I don't know what the turnaround times are on those tests. Certainly here, our turnaround time is 24 hours or less.
Yeah, it's 24 to 30 hours, and I think some of them are still out a little further, 3 to 5 days, although they've gotten better recently.
Marilee in Skidmore, would you address what constitutes a large group in terms of gatherings?
You bet. I am going to be controversial. A large group, A, is a group of people who you're not in contact with on a regular basis. That is, they're outside of your bubble. And B, 6 or more. Hawk?
Yeah, I mean, I think it's 10 on some of the sites, or that's a common number that's thrown out. But with widespread community disease right now, it could be 5 people, and you can have 2 or 3 in that group of 5.
It could be 4 people if you have one of them.
Right.
If you're in a group of folks and you're going to be inside and you're going to be within 6 feet, and some of those folks aren't really trying to follow all the rules of infection control, then that's a big group gathering.
Yeah.
So I would just, size is not as important as behavior. Here's an example. I say this all the time. What's the hottest spot for COVID-19 potential transmission in every single town in the United States? Where is it? It's not the bar, it's not the restaurant, it's the hospital. We have by far the most concentrated number of COVID patients, yet our disease transmission from a patient to a staff member is virtually 0. It may be 0. Sometimes it's hard to do all the contact tracing, but it's virtually 0. And the reason is we follow the rules of infection control, so we keep people safe. So you can stay safe. It's totally dependent upon your own behavior. And so if you go out into a group gathering of 4 or 6, you go to a restaurant, you take your masks off, and the restaurant's a little crowded, you're not safe. I mean, I know you want it to be safe, but you're not safe. And you want to just say, fine, just give me COVID. Right? I'm young, I'm not going to get sick. Okay, well, that's good for you, but what about all the people you can transmit it to? Folks, we have to bend the curve. Kansas City's in trouble. And the only way to do that is for you to exercise the power of kryptonite. You can be COVID's kryptonite. Right here in Kansas City, that's what we need. Next question.
Gary and Anil, remember Anil?
You bet.
Hi, Anil.
Hi, Anil.
They want to know if we get the vaccine, who gets it first? How's it going to be distributed?
Yeah.
Are we one of the health system? Is our hospital going to be participating?
Yeah, so I think we know some of this answer, Hawk. We know that there's a wave 1A, 1B, 2, and 3. Now, in fairness, with an election, some of that could change with the new coronavirus task force, but I don't think it will, because it's the same way we would distribute it. It's the same way we did remdesivir. It's not like we're reinventing this. It's what you would do any time there is a crucial illness. Who do you go treat first? And the answer is you take care of the sickest of the sick. The first wave of patients is going to be nursing homes and those who are older and need that therapy most emergently. And you're going to do frontline healthcare workers, because if you don't have healthcare workers, then you're not going to have people to take care of those folks. And then you're going to do first responders like police and fire and et cetera, and then essential workers along those. So that's kind of so there's a hospital path, and then first responders, essential workers, et cetera. And there's a patient care path, and it's the sickest of the sick, like nursing homes. And then there's different gradations all the way down to you're young and healthy. And so it's going to take probably, it's been said, around a year to get everybody vaccinated. But you can, we think at least, I believe I'm right, Hawk, I read that the United States had ordered 100 million doses of the Pfizer vaccine to be due sometime around the 1st of January. That's a big number.
Carol says, where are the increases coming from? Schools, sports, venues, restaurants? I'm stumped.
Hawkeye, it's coming from everywhere.
Yeah, again, we think it's probably less things like schools, where there are pretty good protocols put in place for those specific school districts and buildings. The de-densifying, the hybrid stuff, the masking, all of those things. I think it's more of the outside getting together in the groups, whether that's 6 or 10, whether that's getting together for a party or a birthday party or things of that nature. And that will include everything, but I think the schools themselves really seem to be okay with much less spread than we thought it would be. But it's when everybody is getting together outside of that school building.
Yep, I think the answer to this is found in behavior. It's not found in location. And this is important. People want to blame the school opening. Well, it's probably not the opening of schools. They did do a good job. The data right now looks really good around that.
Yep.
But when kids get together outside of school in the mask are on, well, you see that's behavior. If you go into a bar and restaurant and take off your mask, well, you see that's behavior. If you go into your neighborhood and you have a big neighborhood party and people are outside, but you're within 3 feet of each other and you're talking to each other really close, you've had a few drinks and all of a sudden the masks are off, well, I don't care if you're outside. If you're that close, that's behavior. Behavior is defining where the spread is occurring more than location. So don't look at location, look at behaviors and recognize that's where the risk is. But it's also where the opportunity is. Because if behaviors are defining where spread is occurring, behaviors can define how we bend the curve. And that's what we just got to go back to the basics. Behaviors define the spread, behaviors define the bend. Be the bend, let's fix the curve.
Lori, she has a 24-year-old daughter who has asthma. She was exposed to COVID by a coworker. Lori wants to know, is there anything more that she can do, like taking a baby aspirin, or vitamin D, or zinc, or vitamin C?
Hawk?
No. Those supplements are all good, I think, for your overall health. Taking them in the prescribed doses is on the bottle. But as far as prevention or protection from progression to severe disease, none of those things have really been vetted out to show that there's any benefit of doing those things.
Jim, you have young kids. How are you trying to keep your family safe?
Well, we actually are fortunate. We are in school because they're young elementary. The school has done an outstanding job. My kids actually get in the car and continue with their mask on, because it's just become so normal.
Yeah.
They don't even think about putting it on or taking it off. We have been very, very restrictive, not letting our children, unfortunately, I'm sure their wants to go out in the neighborhood and play. It's the people that we know. They've got 2 cousins. They're as restrictive as we are, and that's about all they're seeing these days. We've been very restrictive on athletics. Anything that can be done. Through the fall, we did participate in some that were outside, allowed us as parents to be very social distance and then mask wearing. But as we're going into inside sports, I have to say we have essentially negated that for our house, because the risk just goes up so significantly that, we have 2 healthcare providers in our house. Yeah. We have other healthcare providers in our family. And we just can't take that risk because we want to be here for our ultimate purpose, which is to take care of patients.
Yep.
Dr. Monks, what do you say to families? Because we know that Thanksgiving's coming. People are going to want to gather again. What do we say to people to say, look, we got to get through this together. Help us ease that pain a little bit.
Yeah, I think that's the most common question I've gotten in the last couple weeks is, what do I do about Thanksgiving? And we've just kind of been standing by the message of you have to do what you have to do this year so you can be here to have a somewhat normal Thanksgiving next year. Like, making sure people are really thinking through the risks that they're going to take. And if they are going to take a risk and get together with family, keeping it small, under 6 people or less, your core people that are already in your bubble. Just reminding people that we want you here next year so we can do Thanksgiving and the holidays a little bit more normally, and the sacrifice now is worth it.
Yeah, COVID weariness is real.
All right. Michael is wanting to know, what is the percentage of missed tests and treatments that's been due to a person's choice versus lack of available services? Because we talk about being too crowded with COVID to maybe get people in. He's wanting to know, which is it?
Yeah, so we haven't denied people service here. I mean, the only time that was true is back when we closed our clinics and through April and the first part of May. Since we've reopened things, we've been telling people, come on, let's go. We got to get your care. And so we are not restricting care today. Now, if hospitals and health systems in the Kansas City metropolitan area begin to get overwhelmed, that can change, and you may be running. So this is actually a time to go get that stuff done. If you look at El Paso and places right now that are the hottest spots where patients aren't able to go access care because they are too full, the way we avoid that is by personal responsibility and, again, trying to bend the curve. So I think right now you should not be that there aren't patients being denied care who are seeking care, and I think that's a really important statement, Jamie. Don't you think that's true for mammograms and breast cancer?
Absolutely. And I think that as a health system, we've been very thoughtful on how we've been able to keep some of those things going. We know that we've got a lot here on the main campus. That's not where women have to go for their mammograms and ultrasounds, and that's where actually not even the predominance of our surgeries are done or chemotherapy is done. So we're finding very isolated, even higher level protective places and ways to take care of these cancer patients.
One more
Isaac
question.
wants to know about monoclonal antibody. He said that he read somewhere that monoclonal antibody therapies could possibly confer immunity for as long as 2 months. Should we get it like a vaccine?
I think we're kind of missing the things a little bit, so let's talk a little bit about what that means, Hawk.
Yeah, so I think really you can have degradation of these monoclonal antibodies probably within 60 days or so of the infusion of that cocktail. But right now there's really no evidence of using it for a prophylactic measure or such as a vaccination type measure. We do think they will be beneficial. Certainly the early indication is if you get it in the right time frame, and mostly that looks like it's earlier in the disease process, say 1 to 3 days after symptom onset, that it will have a positive effect, but we are still waiting for those full results as well. But as far as using it as a vaccination and going to get that every 60 days, I don't feel that number one, I don't believe that's being looked at, and I don't feel that's really feasible as well.
Yeah, there you go. All right, well, as we wrap up today, Dr. Monks, let's first turn to you. What parting words of wisdom and hope can you give us?
Hold steady. We're going to get there. I know people are exhausted of this, but humans are resilient. We're designed to survive. So I think we're all going to get through this. We just have to do our part and remember that we're doing our part not just for ourselves, but for those around us and people that we care about.
Thank you, and thanks for being with us today, and thanks for all the great work you do. Jamie Wagner, final thoughts.
Somewhat of what I've been saying since summer is unfortunately cancer doesn't stop for a pandemic, and we have really great treatment options with really great survival, but only if we can get to you early. So please do not forget about the rest of your health care and be your own advocate.
Hawk?
Yeah, I think we have the new announcement of the COVID task force. I think this is a really good way. Depoliticize all this, use the science, use the medicine, use the public health measures to really try and protect people. There are so many dynamic details within this. Nobody wants shutdowns. We need to keep the economy going, but there are safe ways to do it and decrease the risk as much as possible. And so hopefully we are on that path now to being able to do that, even as we see cases to rise. Understanding what the real information and the science is and using that to help inform our decisions moving forward.
I want to thank all of our guests today. Great work, and so appreciate the great work that you guys are doing out there. And tomorrow, imagine fighting cancer and learning you've caught COVID-19 at the same time. That's a story of our guest, Carrie Rawley, who shares that story along with her medical oncologist, Laura Nye. Cancer themes because man, it really rings true. That 50% reduction in cancer diagnoses of breast cancer, that scares me, right? That scares me. So thank you guys for that conversation today. You know, you've probably noticed we're a little edgier today, and we're a little more on edge. Things are not good, folks. And I think we have more risk than we've had at any time in the pandemic here in Kansas City. And the only way that we're going to handle that risk is because your behaviors have to help define the shape of the curve, because that's what we're emphasizing. It's really about you. We're going to be here to take care of you if you get sick. We don't want to be overwhelmed. And the only way to solve for that is by following the rules of infection control. Science works. We know that it works. We can see the vaccine development coming. We can see monoclonal antibodies coming. We can see new other novel therapies coming. We can see better testing coming. All those things are true because science works, and it works for you. And the way you can help us get there is to help bend the curve by following the rules of infection control. They travel with you everywhere you go. So remember, until we're back with you tomorrow, there's still no place like home. We've got a little video for you right now about frontline nurses asking folks to wear their mask. Stay with us. We'll see you tomorrow.
Please wear a mask. This is no one is making this up. This is real. This is happening here. This is happening in our community right now. We need to get serious about this. In April, I cried probably after every shift. I lost 2 patients this week. It's been very, very difficult. The second patient, he had been with us for quite some time, and we loved him and we loved his family, and your heart just breaks for them. At the end of the day, me holding their hand and me, speaking to them is not the same as their wife, their son, their mother. It's not political anymore. This is just a matter of life and death, and it's a matter of survival. Wear your mask, stay home if you feel sick, and wash your hands. I mean, it's not difficult. It's really not difficult. Keep your family safe, keep your community safe, keep yourself safe.